Hey, my name is Chris. Thank you for tuning in. I'm going to be going over a series of chief complaints that patients will present with in the OB triage setting. The first video today is going to be about decreased fetal movement. So to start off with fetal movement first, it's usually first assessed by mom roughly between the weeks of gestation of 16 to 20. The first movement is defined as quickening, and roughly around out of all the patients who are pregnant, 40% will endorse decreased fetal movement. And in the third trimester, roughly 15% of patients will contact their primary OBGYN about decreased fetal movement that they've experienced. There is no clear consensus on the diagnosis of decreased fetal movement, although the providers in the area that I work commonly use a count to 10 method. This count to 10 method is when you have mom do a focused kick count. She will be laying on a couch or a bed without distractions, no TVs, computers, phones, music, and the hand's gonna go on the abdomen and they're gonna count up to 10 kicks. Once they reach 10 kicks, they can stop the counting exercise and go about their daily activities. The issue is that fetal sleep cycles can last up to 40 minutes, and that's why they usually do a 2-hour window to assess. When that was assessed, like in a study population, kicks usually were achieved by 20 minutes. Like total of 10 kicks was achieved by at least 20 minutes. So they didn't have to go the whole 2 hours. But, patient does that at home, reaches the alarm limit, so it goes 2 hours without getting 10 kicks, and now they're gonna come into OB triage. So as a provider, there's certain things you have to think about now. So when they come in, they present with that. Make sure you're ruling out that there's no contractions, there's no vaginal bleeding, no leakage of fluid. And then once you finalize that it's really only decreased fetal movement, then she goes right on the monitor. And this is external fetal heart rate monitor, and this goes on the abdomen. They can put a tachometer as well to look for contractions, but they're gonna go on immediately. And during that time, they're gonna wait for 20 minutes at least, which is the time that you're gonna need for a non-stress test. And I'll go into it a little bit, but that's why you're gonna start there. While they're on a monitor, then you can start asking all your questions. History and physical, you can review their perinatal records and figure out if there are certain things that might have, been extra complications, or if they're seeing an MFM doc, then that's like really good for you to know and assess. But anyways, so they're on the monitor right now. And the reason why is because they wanna first perform an NST. And the NST, if it's reactive, so like if they're under 32 weeks, they need 10 by 10s for their accelerations, and they need 2 of those in that 20-minute window. And if they're greater than 32 weeks, then it's 15s by 15s. So 15 fetal heart rate beat average above the baseline for 15 seconds. That's what 15 by 15 means. They need 2 of those within the 20-minute window. So if they achieve that without like decelerations, then they have a reactive NST, and that's reassuring. And so, you have the 3 things. So you have your history and physical, reviewing perinatal records, you have your NST that's been currently conducted. And then really once you kind of get that good 20-minute strip, then you can do your ultrasound. And this is a transabdominal ultrasound. So you're gonna bring it in and you're gonna assess for fluid. And the things that you're gonna look for fluid is, DVP or AFI. And if it's a DVP, less than 2, that's concerning. AFI less than 5, and that's concerning. So now you have your kind of like your metric of like these 3 things that you're gonna be looking at when patients come in with decreased fetal movement. And now kind of going into the understanding of why we're doing that. So the NST by itself, if you're just doing that, the reason why you're doing that is if it is a reactive NST, we can then quote the patients that the risk for stillbirth within the following week of that successful NST is going to be 1.9 in 1,000. Additionally, with the ultrasound, you can also do a biophysical profile. And I will list like the main components of the biophysical profile right here, but they're fetal heart rate, breathing, movement, tone, and fluid, which is the modified BPP. But those are the main components. I'll put up a little thing right here about like what the duration of breathing is supposed to be, how many tones, how many movements, so you can do it right here. The importance of this though is that aside from the NST, which was 1.9 in 1,000, if you're doing a BPP or a modified BPP, modified is when you're adding in your fluid level, then it's 0.8 in 1,000 for the risk of stillbirth in the following week. And if that is the case and that's still not reactive, then you can look at a contraction stress test, and the risk for stillbirth in the following week after a successful one of those is down to 0.3 in 1,000. The last thing I want to talk about as well is when you're looking at, the BPP or modified BPP, there's actually a differentiation on how patients should be managed given those findings. So breaking down all the different components, you get a full score of 2 for it, so a total of 10. And if it's above 8, then that's reassuring. But if they lost points on decreased fluid, what their score of being 8, and they're greater than 39 weeks, then they should be going for delivery. And if they are 6, and that's called equivocal. And if they're 6 and equivocal, and then you have to look at, is it because of fluid that they lost 2 of the points, or is it because of other things like breathing, which is probably the most common one. So if it's abnormal AFI or abnormal fluid, then consider delivery if they're under 37 weeks. And if it's a normal AFI, then you can reassess within the 24-hour window. And this is all to reduce the fact of, risk of stillbirth within this population. So that's pretty much the whole video on decreased fetal movement. I'm going to be doing a couple of these on vaginal bleeding, loss of fluid, contractions, and hopefully they will help assess and develop your knowledge of how to manage these patients who come into a triage setting. Thanks for tuning in.